Welcome. I'm Dr. Ken Pisel, and I'm going to talk to you about prostate cancer from the patient's perspective. Most things you will find online on YouTube deal with prostate cancer from the medical practitioner's perspective. I refer to prostate cancer as a silent killer because men don't talk about it. Whether it's ego or embarrassment, they tend not to address it. So there are issues that I think you need to know and maybe have been avoiding asking. A disclaimer on my part. I am a PhD, not an MD. I am not a medical professional. All my adult life I've been in the Navy or working within the Department of Defense. In a past life I used to fly helicopters and have a good time. As I approach 68, I'm retiring from higher education. I am not now and have never been a medical doctor. So any advice I give you will be to consult a medical professional. I can philosophize about the disease, but I have no medical opinions. That said, I've had a vested interest in prostate cancer since 2001. I'd like to show you the mistakes I've made and the consequences of them. A quick agenda. The first thing I want to do is inform you. I also want to grab your attention. Going back to my Navy background, I had a much more graphic phrase for that of scaring the living, but that's neither here nor there. But ultimately, I want to make you aware. I also have a personalized approach to cancer. I consider it a living entity, which it is, but it and I are in a battle. The more people that I make aware of prostate cancer and deprive cancer of killing, the more I've won this battle. Do you have a purpose in life? It appears that I do. I provide a bad example that enables others to learn. I shattered my femur back in 1995. If you look at the picture, people talk about being screwed. I've got photos to prove it. I am screwed, literally. The generation of folks that worked at the college where I've worked for the last 27 years had a deep appreciation for gravity back during that time frame. There would be 1 to 3 Mondays each month where someone would say, I thought about you this weekend. In other words, they were about to climb a ladder, climb a tree, go on a roof or something and realized gravity is not your friend. It will hurt you. Having survived that, I'm looking at something new to address, see if I can inform and make people aware, and it's prostate cancer. What do you know about prostate cancer? I would surmise that unless you have it, a member of your family has it, you're a medical professional, or you have a hobby of reading medical journals, you probably don't know as much as you potentially could. Did you know that prostate cancer is the second most common cancer for males? September is Prostate Cancer Awareness Month. There are a whole bunch of ribbons out there for prostate cancer awareness. Prostate cancer is light blue. And just to prove that the folks who have come up with these colors have a sense of humor, the one for bladder cancer is yellow and the one for colorectal cancer is brown. You didn't see light blue displayed rampantly throughout September like you saw for pink displayed in October for breast cancer, because breast cancer has a much better marketing program. If you've ever seen the bumper sticker, Save the Tatas, how do we compete with that? You will see Major League Baseball wear light blue on Father's Day, which really makes no sense because you don't have to be a father to have prostate cancer. So if you see something online talking about share this ribbon if you support cancer victims, and it's pink, you're talking about breast cancer victims. Lavender or purple is general cancer. It's also pancreatic cancer. Pancreatic cancer has no sense of humor. Prostate cancer, as we'll discuss, gives you a little more flexibility. The prostate is a walnut-sized reproductive gland wrapped around the urethra, stuck between the bladder and the rectum. It secretes approximately 30% of your seminal fluid, so it has a function. Prostate cancer is obviously when you have malignant cells, cancer cells, inside of the prostate, you have prostate cancer. The graphic on the right shows that about half of the prostate has cancerous cells. This is stage 1 prostate cancer. It's limited to one of the 2 lobes of the prostate. It is a comparatively slow-growing cancer. In many cases, there are no symptoms for prostate cancer. In fact, for 17 years, I said I had no symptoms. The reality is, once I started developing this presentation, I realized I did have symptoms. I was just not aware of it. If you do a simple search online, you will come down with the 7 symptoms below, maybe a few more, but they're very representative of what you could potentially see. As a layman, I've broken them down into 3 brackets. The first is urination. If you have difficulty urinating, if you have more frequent urges to urinate at night, if you have decreased force in the stream of urine, that's your first indicator that you really should get this looked into. If you go back to when I was in my mid-40s, I'm approaching 68 now, but I would go into the stall at work, achieve my mission, come out, and immediately go to the urinal. I remember having the thought, well, that's different. Not, that's different, I wonder why. That's different, I should get this looked into. That's different, I should talk to a doctor. Nope, that's different, and just pressed on. Ignored it completely. The next bracket, erectile dysfunction. This will tend to get men's attention. Over time, there will be more and more erectile difficulties. The last bracket I refer to as just the stubborn bracket. If you've got blood in your semen, discomfort in the pelvic area, or bone pain, you've ignored an awful lot, and you're probably in stage 4. So take advantage of the ability to recognize the early urinary symptoms and ask about them. Recognizing them alone accomplishes nothing. Talking to a doctor is where it starts to get serious, and you get serious about it. Diagnosis is really a 3-step process. First, there's the DRE, the digital rectal exam. Men have many euphemistic names for it. My personal favorite is the fickle finger of fate, but it's a physical inspection of the prostate via the rectum, pressing against the bladder, and looking for lumps, looking for enlargement. A trained medical professional can tell if there's an irregularity in the prostate. There may or may not be an enlargement. The next step is PSA, prostate-specific antigen. That is a blood test. The normal range is from 0 to 4. Only 2 things can generate a PSA, a prostate and prostate cancer cells. The final diagnosis will either be by biopsy, transrectal ultrasound, or transrectal MRI. Back in 2001, when I started this whole thing, I did not know about ultrasound or MRI. I believe that they are newer technologies. It's up to your doctor to tell you which one is best and which one they are using. But when I did the biopsy, my doctor prescribed for me Tylenol 3, Tylenol with codeine, take before I came to the office. So I'm lying there on my side with everything exposed. And the snap of an empty plastic cap gun from my childhood would happen, and I'd feel this strange sensation. And they took 10 samples. I went home, floated into the house, not touching the floor at all, and proceeded to debate with my wife what to do next. I was going to read the paper. She said I should go to bed. I won the argument. I picked up the paper. I could not read any of the words, so then I went to bed. But I'd won the argument. That was all that mattered. A very close friend has had a biopsy, and he said that after about the second sample, he asked the doctor, I don't think I can stand this. How many more samples are you going to take? The doctor said like 8 to 10. At this point, my friend told him, when I get dental work done, they have to give me 2 shots of lidocaine before they kill the pain. At this point, the doctor got this strange look on his face that would have been a handy piece of information to have. So if you need extra lidocaine at the dental office, when someone is climbing up your butt to take tissue samples, I'd let them know up front. The Gleason scale is where they take cells from the biopsy, thread them on a microscopic plate, and are able to tell you the aggressiveness of your personal strain of prostate cancer. I forget mine, so I'm not going to talk about it in any detail. Your treatment options. First and foremost, this is something you discuss with your doctor. Don't take anything I say here as gospel. They are things that could be done, not what I say should be done. Watchful waiting, doing nothing, is an option. Anytime you do planning, more times than not, you will have let's do nothing as an option. First, do no harm. If you are in your 80s and you've been keeping track of your health, and this is the first time you've been diagnosed with prostate cancer, there's a fair chance that the doctor may recommend active surveillance, just waiting to see what happens. It's slow growing. Something else will probably kill you. Surgery, the prostatectomy. The radical prostatectomy, if you remember I said that it's wrapped around the urethra. Well, they don't slice it off the urethra. They chop off at the top and the bottom and then pull in the excess tackle and connect it all back together again. Nerve sparing. I did not have that done, But nerve-sparing prostatectomy is a procedure where you have a greater potential for having an erection again in the future. I would think, and this is just opinion, that you're probably going to be in stage 1 to be qualified for nerve sparing, but that's up for you and the doctor to discuss. Radiation therapy. You've got photon beams, X-rays, proton beams, and the IMRT, which is more or less a combination of the two in terms of its effectiveness. Photon is the X-rays, going back to my Navy roots, are dumb bombs. They're going to blast the living daylights out of anything they find there and anything in the neighborhood. The proton beams are smart bombs. They're going to be focused on the prostate itself. As we talk about side effects, you'll see the difference between the two. Cryosurgery. That's where they freeze the prostate. You'll get a spinal block or general anesthetic. If I were coming up for that, and that's the route we were taking, I would take the general anesthetic. Having read where they're going to shove 2 large needles, they better knock my ass out. I'm just not going to do that. The radioactive seeds, brachytherapy, are either low dose, permanently, or high dose for a shorter period of time. So there are different options that the medical professional can choose depending upon where you stand, how old you are, what the severity is, etc., etc. Let me talk about 2 of the more common procedures and their side effects. With the prostatectomy, you're in the hospital for a couple of days, a month at home, and 1 to 3 weeks on a catheter. If you've never done a catheter, it's a whole new experience. As with anything else, you become accustomed to it. Personally, after a couple of weeks, I had the hook that's on the collection bag. I would put it on the pocket of the gym shorts that I wore around the house. One day I sat down to have lunch, took it off my pocket and put it on the chair, and then forgot to put it back on my pocket as I walked away from the chair. At that point, I made a noise that has permanently scarred my then college-age daughter. Ironically, the only other time that I caught the tube and yanked on it was later that same day. The most anxious I've ever been in any medical procedure is when they took out the catheter. And the most wasted use of angst ever was that event. Because there is a little bulb in the bladder filled with saline that they snip the tube to, it deflates, and it comes right out. So you get tense and it's over. It's a non-event. Wasting time when getting worried about things is a fool's errand. The pain. The pain is no greater than any other surgery I've had, and having fallen out of a tree, I've got some experience with surgeries. Incontinence? Yes. Depends will be your friend. You will have incontinence. It will improve. The appointment I had after the surgery, so they gave me a urine sample cup, and I'm standing there filling it up. I send the signal from my brain to my bladder to stop the flow. And I just stood there and watched it continue. Again, profoundly, I'm thinking, well, that's interesting. You've got to relearn how to control the sphincter to your bladder because things have changed. Bowel problems. Until I read more into this, I didn't realize that bowel problems were a potential option. I had none personally. Fatigue. I had no fatigue from this procedure. But fatigue is something that's not simply being tired. I'll talk more about that later. Erectile dysfunction. Yes, there will be erectile dysfunction. Your chances of an erection are slim. So enjoy it while you've got it. Radiation. Up to 2 months fatigue with possible skin reaction. The skin reaction is constantly burning through the skin to get to the prostate at the same point. It builds up over time. It will burn the exterior. The pain is mild to moderate. Again, it'll be a moderate pain in the end as you're dealing with the surface destruction. Incontinence, less than the prostatectomy. But bowel problems. 2/3 of all men get bowel problems. That's because the dumb bomb is taking out anything in the neighborhood. The rectum is right next to the prostate, so it is affecting the rectum. Fatigue is moderate, so there's a different level of fatigue associated with it. Erectile dysfunction, you now have a 26% chance of an erection, so that's better than 6, but you're still not at 100% functional after this. Genetics and timing. I like this graphic simply because it shows a African American male's hand and points out that African American men are twice as likely, almost twice as likely, to develop prostate cancer. I cannot tell you why. It may be simply genetic. If your father, brother, or maternal grandfather have prostate cancer, you are in a higher risk group. If you are adopted and don't know what your lineage is, you need to consider yourself in a higher risk group. If a member of your immediate family has a history of cancer, I'd consider myself in a higher risk group. If you look at my paternal side, my paternal grandmother died from ovarian cancer. She had 3 children. The oldest dodged the bullet by getting himself killed in a car accident when I was 3. The middle child, my father, died after having prostate and colon cancer. His sister, the youngest, died from liver cancer. There is a strong history of cancer in that side of my family. Actions. Talk to your doctor. If you're in a high-risk group, get your PSA screening done and establish a baseline. A good rule of thumb is 10 years prior to the diagnosis of the closest member of your family, start your screening then. Okay, here's my story. I got a physical at age 49. At that point, I was a year short of 50. That was the benchmark back then of when you really should start looking at prostate cancer. I knew my father had been diagnosed with prostate cancer in his 60s, and it may be that that's when they had just started coming up with the PSA. So my general practitioner and the urologist both said, after the DRE, I had a small prostate, but the PSA was high. So we went on and did a biopsy. 10 of 10 samples were positive. It's now in both lobes at stage 2. The prostatectomy was on the 13th of July, it was a Friday, 2001. The lymph nodes were clear. The follow-up exam, my PSA was 0.74. What does that mean? If only 2 things can give you a prostate-specific antigen reading, a prostate or prostate cancer cells, and you no longer have a prostate, there are cells floating around there looking for a place to homestead. Cancer cells have escaped the capsule. This is stage 3 prostate cancer. There is no cure. I have subsequently done 5 clinical trials at Johns Hopkins in Baltimore. They have tremendous prostate cancer expertise. Depending upon where you are, you may consider reaching out to a major clinic to find out who has the greatest expertise, who can do more in terms of clinical trials, who knows what. I know locally where I am, in Virginia Beach, a good friend's wife had breast cancer, and they went south to Duke. Equidistant in the opposite direction is Johns Hopkins. The man that wrote the book on prostate cancer is up there. I went up there. So there's a lot of expertise out there, but find the best you can, as close as you can, and go to it. Clinical trials. This is your opportunity to become a guinea pig. There are 3 phases of clinical trials with different size populations, different outcomes that they're looking for. You may or may not qualify for a clinical trial. It depends on the population size, your stage of prostate cancer, and past treatments. You may have done something already that takes you out of the running for that particular trial. I'm actually engaged in a 5th trial. The first one, I can't remember what exactly it was. I'll talk more about the symptoms on the next slide. But the man study is a combination of chemo and hormone therapy. Hormone therapy is one of the great terms of our time. There are some states that prescribe chemical castration for things like child assault. Hormone therapy is chemical castration, but doesn't it sound nicer than chemical castration? It is preventing the body from creating testosterone. Testosterone is the primary fuel for prostate cancer. This is essentially the game of whack-a-mole you find in an arcade. You start off with hormones, take you down to 0, and then the Friday before you do chemo on Tuesday, you rub testosterone gel on your chest to feed the disease so that it has something to attack when you do the chemo on the following Tuesday. Every 3 weeks we go through the cycle. ATN-224 was a vascular inhibitor, the theory being that if the Tumors cannot develop the vascular system, the capillaries, etc. they need to develop. You've retarded the disease. Herbal treatment was an antioxidant. It was a crushed grape seed. And right now I'm doing 2 drugs that have been approved for melanoma and kidney cancer. There are myriad clinical trials out there. You may or may not qualify for them. So talk to your doctor, and the more your doctor is involved with a major clinic, the more likely it is you can find something new. Side effects from the clinical trials. Sinuses on the first one. I never knew that there was a link between reproductive organs and the sinuses. If you ever have the opportunity to take Viagra or the other erectile dysfunction drugs, one of the side effects is sinus congestion. Well, this drug itself was giving me sinus congestion, so I was getting marginal effectiveness from Viagra, but all the effectiveness of the sinus congestion, so I couldn't breathe very well for 2 days. The man study, 10 cycles of chemo, hair loss. About 2 weeks into the first cycle, I boasted that I haven't lost any hair. The very next morning, taking a shower, I looked down and there's a small dead animal lying there on the shower floor. For the next 3 days, I'm taking out hair by the handful and stacking it on the end table and the coffee table. I had to make a decision of, do I take my chances with cancer, which I know I potentially can beat, or just keep stacking hair all over the place and take my chances with my wife, who I know is going to kill me. I'm not going to mess with my wife. I shaved my head at that point. Loss of taste. You will start, at least I did, eating more and more spicy dishes, things that you could actually taste. You may actually find yourself bleeding the following day because you found something that was really good. Lactose issues. I was not told about lactose issues until a friend of mine, who retired Army Lieutenant Colonel, who became a chef, asked me how I was doing with lactose intolerance. She was developing a menu for another friend who was undergoing chemo, and lactose intolerance was an issue. I cut out lactose and found out that the backflips my stomach had been doing abated. So be careful of lactose. Chemo is killing the enzymes that deal with lactose. Fatigue. Let's talk quickly about fatigue. Fatigue is not simply being tired. Fatigue, and I told my boss prior to starting this clinical trial that I'm going to have fatigue. That just means I'm going to have to push myself hard to work out at lunchtime. That was not the case. Fatigue is your wife dropping you off the door, telling you, make sure you take the elevator, you saying, yes, dear, then being a dumbass, you get on the stairs, and you stop the landing between the first and second floors to rest before you take the second half. Fatigue is extremely draining. Neuropathy. I've lost the feeling in the balls of my feet, and that has endured since 2006 when I did that clinical trial. Swelling in the lower legs and feet. I had bell-bottom ankles and difficulty getting my shoes on. And pain. If you look at this chart up here, the Tuesday is when I do the chemo. I'm perfectly fine Wednesday and Thursday. Friday, the pain cycle set in. Friday, Saturday, and Sunday were very painful. It was difficult to sleep because you couldn't find a place or a position that was comfortable. Monday, I was more or less back to normal, but I would work from home simply because I would have been bad for morale. Tuesday, I came back into work, and Wednesday, I was normal. And I'll put the word normal in quotation marks because it's a step down from what normal was the week before. Every chemo cycle, you're knocked down a notch. It's a cumulative process. Hormone therapy. Now that's a lot of fun. You become large, bald, menopausal woman as a guy. I had hot flashes, I cried at chick flicks, loss of muscle mass, and weight gain. I gained close to 50 pounds on that trial, and it was, I lived in a zone where I would not watch Oprah or any chick flick because I would just end up crying. For being a sarcastic, sardonic curmudgeon all of my life, suddenly crying at things was a whole new world. The ATN 224, I would take the dogs for a walk, even on a cool day, put on gloves, come back, and The first two fingers of my hand were white from lack of blood flow. It took me a while to get circulation going back into them. The herbal treatment had none of note. The fifth one I'll talk about in a future slide. You remember I said that the PSA should be between 0 and 4. Well, once you get to the post-failed prostatectomy, all the numbers go out the window. There is no longer a normal. I've been down to undetectable, and right now I'm up around 293. It varies over time. It's gone up, it's gone down. The two charts below show a couple years, and I'm doing a quarterly blood test with this disease, and I'm bouncing between 35 and 45 over these years. Eventually, I get to the point where I hit 45, 50, 60, 70, 140. Concurrently, you'll see alkaline phosphatase, which is a liver function that may indicate metastatic activity in the bone. That takes off, should be around 39 to 117. I'm over 2,000. So they had my attention at that point. The bone scan that I got in February of 2016 indicated that it had in fact metastasized to the skull, spine, ribs, pelvis, and femur. I'm now stage 4. Once I was diagnosed as metastatic, I started hormone therapy. I will be on hormone therapy for the rest of my life. I became hormone resistant in February 2018, 2 years later. What that means is that nature finds a way. The prostate cancer cells develop the ability to create their own fuel. So I started a drug called Zytiga. The average success range is around 17 months. I failed at around 13 months. Somebody has to be on the left side of the bell curve. And we switched to enzalutamide. The bone scans I had in 2018 and 2019 were super scans. When I first heard this, I was impressed. I thought a super scan, that's like Super Doppler 10, the latest technology. No, that's not how it works. A super scan is when pretty much every bone in your body is lighting up as metastatic. So, I started a 5th clinical trial in August of 2019 and started planning for my retirement. Eventually, I'll move on to bone pain with radium therapy, soft tissue metastases with chemo, something to really look forward to, and ultimately pain management, hospice, people saying undeservedly nice things about me at a ceremony where I'm not really in attendance. Back in May, the oncologist estimated that he'd be surprised if I die within a year, but he wouldn't be surprised if I die within 2 years. Conversely, he wouldn't be surprised if I was alive for 3 to 4 years. Therefore, I'm shooting for 10 years just to see if I can shock the living hell out of him. My goal from the beginning has been to piss off oncological statisticians, be 2 standard deviations out to the right, and have someone ask the question, why isn't that bastard dead yet? What's he doing that's different? Remember that side effects are not limited to just the clinical trials. Any of the treatments have side effects. Because I started hormone therapy back in 2016, unlike the man study where I was done inside of 6 months and redeveloped all the muscles, I've been going on this for well over 3 years and have destroyed all the muscle mass I have in my body. The enzalutamide comes with fatigue. It is up there close to chemo. Not quite as much, but it tires you out. And when you have no muscle mass, just moving around becomes more difficult. Looking at the many various and sundry side effects, I was always tickled with the idea of possible memory loss. Back when I was a helicopter pilot, every year I'd get a flight physical, and you would get this list with a litany of possible diseases and maladies, and have you had this in the last year? Yes, no, don't know. I always wanted to put don't know next to memory loss. How do I know if I've forgotten anything? I don't remember forgetting anything. Maybe I've got it. Right now, I'm not sure if I've got memory loss. Who knows? And they put down death. Excuse me. You're not taking this stuff if you're doing well. Death is definitely in the cards sometime in the foreseeable future. I intend to drag it out as long as possible, but I'm not exactly concerned about death from enzalutamide. In dog years, I am already dead. The clinical trial I'm dealing with has got fatigue and skin irritation. I've not noticed a significant increase in fatigue, but I now itch. I can deal with that. A couple things to think about. If you, a member of your family, someone that works with you, for you, a friend, face cancer or other major medical issue, recommend that they abandon two terms: good news and bad news. These are the rails of an emotional roller coaster. There are only facts. You're putting a label of good and bad on them that they don't deserve. Know what the facts are and deal with them as soon as you can. Don't get wrapped up in the emotion, because if during those few years where it was jumping up and down between 35 and 45, I would become gleeful that it dropped down to 35, and oh my God, it's at 45, I would have been a nervous wreck. I don't worry about things. Worrying doesn't accomplish anything. Have a sense of humor. The late Arlen Specter once noted about chemotherapy that he debated the issue of whether to wear a baseball cap, a toupee, or shave his head and be a sex symbol. He chose none of the above. Personally, I went with sex symbol. I must report that the results have been disappointing. I don't know what I expected from a sex symbol, but it sure as heck didn't happen. Focus on life over death. If you are wrapped up in dying, you've already stopped living. So keep your eyes on a long-term goal. I don't care what the prognosis is in the near term, you're going to beat it. The only thing that I've done that focuses on death is I've planned for my funeral. I've written my obituary. A, I like writing. B, I figure my wife's already having a bad day when I finally kick off. Why leave her the burden of taking care of those things from scratch? In the obituary, I have words to the effect that I've died after a long battle with prostate cancer. In my final act, parenthetically, death, I've killed every one of the cancer cells in my body and declared victory over the disease. Finally, let's focus on you. You will notice that your probability is potentially 1 in 8 over your lifetime. I've seen as low as 1 in 6. I've seen as high as 1 in 9. But if you're a male, you have a fairly good chance of getting prostate cancer. If you do nothing about it, you have a fairly good chance of suffering from prostate cancer. Pay attention to it. The statistics tell us that the number of cases are going up, the number of deaths are going up, men being diagnosed more frequently and dying faster. I've made attempts to make this presentation shorter just in case I kick off partway through. I failed. But know that the numbers are not in your favor. All right, what do you need to do? Know your risk. Remember that if you've got a family history, you need to be talking to your doctor about it as soon as you can. If you don't know your family history, you're adopted, you need to be talking to your doctor as soon as you can. Establish your baseline. Also remember that if you're in the 0 to 4 range, that isn't necessarily the final answer. My brother was diagnosed with prostate cancer because I had been diagnosed and my father had been diagnosed. He was in the 0 to 4 range, but he'd had a physical within a year and he'd gone, I'm making up these numbers, he'd gone from 1 to 3. He's still in the normal range, but his doubling rate was suspicious. So they did a biopsy and he was, I think, 4 of 10 on his samples. So 0 to 4 is not the be-all and end-all. The doubling rate is also an issue you need to keep track of. Get over embarrassment with a DRE. Prostate cancer will kill you. And talk. Talk to your doctor. Talk to your family. Talk to your friends. Ignorance and stubbornness are two of the most endearing qualities of all the men I know. So engage in a conversation and understand where you are and where you're going. A final word of caution about self-diagnosis. I am not singling out any one of these drugs, but the one that I like best is the erectile function drugs. The reason I like those drugs is that they are prescribed by a doctor. You just don't go in and tell the doctor, I've got erectile dysfunction, and they slap some Viagra on you. They're going to test your PSA and see what the cause might be. If you're not having prostate problems, more power to you. The saw palmetto, and I choose that as an example, not as the be-all and end-all. If you look at the various and sundry prostate treatment drugs, their list of symptoms that they treat are the symptoms for prostate cancer. If your doctor says you're clear and this will help you with your frequent urination, getting up at night, etc., more power to you. But have your doctor tell you that, not buying something over the counter and making your own diagnosis. Then you've got Frank Thomas and the Big Hurt. Like, I'm in my 40s now, and I'm not what I used to be, but now that I'm taking more testosterone, I can do more things. Testosterone is the fuel for a disease that will kill you. Know where you are. I have a good friend that was prescribed testosterone by his doctor. He didn't have prostate cancer, so it was safe to prescribe it. Don't just decide on your own that, I need testosterone. I need saw palmetto or prostate aid or super beta prostate to take care of my urinary problems. Look at those as symptoms and then find out why you have those symptoms. Bottom line, there's almost nothing you can do to prevent or avoid prostate cancer. I've seen some things that talk about dietary habits, but by and large, the strongest factor involved is genetics. You have two options for treatment. You can either go for a cure, which is to say, identify it early, fix it early, or go for no cure, and then deal with the consequences. Closing thoughts. This presentation was not medical advice. It was intended to create awareness. Be aware of the relationship between your urinary habits and prostate cancer. Know that testosterone is the primary fuel of prostate cancer. Get regular physicals and know your PSA. If you have questions, consult a medical professional. If you choose to self-diagnose, you may have a fool for a patient. I hope you have a long and happy life.